Good afternoon, good evening, good morning, everyone, wherever you are in the world. Today we have our GLODAM webinar for December, and the topic is DReSS, drug reaction with eosinophilia and systemic symptoms. And we are happy to have our presenters with us, Prof. Roni and Dr. Mira Ahmed. So I'll introduce them in more detail later. Oh, slides are frozen. Okay, but just some ground rules to get us started. Please remember that we have a Q&A section on our chat and a chat function. So on the chat function, you can share with us which part of the world you're joining us from, and also you can share any additional comments you may have about the webinar. On top of that, we also have the Q&A section where you can share any questions that you may have about this webinar, and we'll be happy to answer at the end of the section. So we have other attendants and co-panelists with us who will be able to assist us with that section. We'll also have poll questions. We'll have Josh addressing that, and we'll also have a photo at the end of this section. So if you wouldn't like to take part in the photo, that's fine, because it will be part of something that will be shared on social media. So if you wouldn't like to take part in the photo, you can just put off your camera at the end of the webinar. But for now, happy to join the panelists. So our speakers today are Prof. Roni, who is the head of the Inflammatory and Autoimmune Skin Diseases Unit and the Clinical Associate Professor, as well as EMEC Medical Center and Bruce Rappaport Faculty Medicine, Institute of Technology, Israel. She also works for some institutes in Canada. She's the assistant professor at the Department of Medicine at the University of Toronto, Canada. And she's also the head of international telehealth rounds in dermatology for Canada International Scientific Exchange Program. Our second speaker is Dr. Mira Ahmed. She's a fourth-year dermatology resident at EMEC Medical Center in Afula, Israel. So with that, I'd like to move on to our speakers, and I'll stop sharing the slides.
Thank you for the introduction. Good morning and good afternoon, everyone. It's an honor to open this session and to be here with my mentor, Professor Dodiuk-Gad, and to share our experiences with you today. In the first part of this talk, I will present a patient with DReSS who was admitted to our department last month. Later, Professor Dodiuk-Gad will share her extensive experience and insights related to DReSS. Our patient is a 25-year-old Arab Muslim female. She's divorced and a mother of 2 children. In October 2024, she was hospitalized in the psychiatric department due to an adjustment disorder that developed following a traumatic event earlier this year. During her hospitalization, the following treatment regimen was introduced. On October 2nd, olanzapine was initiated. By October 22nd, a combination of lamotrigine, lorazepam, escitalopram, and mirtazapine was added to her regimen. In October 30th, trazodone was introduced. On November 9th, the patient developed the first symptoms during psychiatric hospitalization at another medical center, which included severe pruritus of the scalp and genitalia, as well as a rash on her chest. On November 12th, she was discharged from the psychiatric department without further assessment. By November 18th, her condition had worsened with generalized pruritus and a burning sensation affecting her entire body. She consulted her family doctor, who recommended antihistamine, but there was no improvement. On November 22nd, she experienced a high fever accompanied by vomiting, breathing difficulties, a burning sensation during urination, a genital discharge, and the spreading of the rash across her body. Due to this deterioration in her medical condition, she was referred to the ER for further assessment. On the ER, the physical examination revealed a morbilliform rash on the trunk, upper extremities, and lower extremities, involving more than 50% of her total body surface area, without mucosal involvement or lymphadenopathy. In the emergency room, the patient underwent a workup which included the following. Complete blood count showed leukocytosis with no eosinophilia. Chemistry results were as follows. Creatinine was within normal limits, and liver function tests were normal. The urinary dipstick showed a pathological results. A chest X-ray was performed and was normal. And finally, the gynecological examination was unremarkable with no significant findings. These results were used to guide the differential diagnosis and further management of the patient. She was examined by a dermatology trainee in the ER, who suggested a differential diagnosis of drug eruption due to the recent multiple drug use. However, DReSS was considered less likely due to the absence of eosinophilia and lack of systemic involvement. Therefore, the possibility of an infectious process was highly considered. Accordingly, the patient was hospitalized for further assessment. Based on this differential diagnosis, all the psychiatric medication were discontinued, and prednisone and intravenous ciprofloxacin were started due to a suspected urinary tract infection based on symptoms of burning sensation during urination and the pathological urinary findings. On the second day of admission, the patient was re-examined by Professor Gad and me. We questioned the patient about her facial appearance and whether she had noticed any changes, such as facial edema. On the physical examination, it was not clear to us whether she had facial edema. Therefore, we asked her to share a photo of her face taken prior to the rash. By comparing it to her current appearance, it became very clear to us that she had facial edema. Furthermore, we examined her ears, which were clearly edematous. This is a key factor in assessing facial edema. Out of respect for the patient privacy, we are unable to share photo of her face. To sum it up, following the introduction of a new medication during hospitalization in the psychiatric department, with variation in the time between 19 to 39 days, depending on the medication, the patient developed pruritus of the scalp and genitalia, and a rash on her chest, followed by generalized rash and fever. Physical examination revealed facial edema, strongly raising the suspicion of DReSS. Even with tools like the RIGI scar scoring system, the initial score was low. However, the presence of facial and ear edema, along with the history of a new medication, raising a high suspicion of DReSS. The next step involved a thorough clinical history to identify the culprit drug. This included considering all medication with a focus on those most commonly associated with DReSS, based on context and medical literature. DReSS reactions typically occur 2 to 6 weeks after starting a medication. In this case, lamotrigine was the most likely suspected cause. During hospitalization, the patient underwent a full diagnostic workup. Her complete blood count showed leukocytosis, but no atypical lymphocytes or eosinophilia were observed on the blood smear. Her chemistry panel was normal, including creatinine, amylase, lipase, troponin, and creatinine protein kinase levels. Initially, her liver function tests were also normal. Serological testing for human herpes virus 6, hepatitis B, hepatitis C returned negative. A chest X-ray and electrocardiogram showed no abnormalities. Additionally, evaluation by both a gynecologist and an ophthalmologist were unremarkable, with no pathological findings. However, 4 days later, eosinophilia and an elevation in alanine aminotransferase were noted. Therefore, lamotrigine was discontinued earlier and not renewed, while other psychiatric medication were resumed. Typically, we prefer not to renew medication in such cases, but this decision was made in collaboration with the psychiatric consultation due to the patient's emotional state and suicidal thoughts, as a systemic steroid can exacerbate emotional distress. The renewal of psychiatric medication was done alongside the continuation of prednisone with the addition of topical steroids and antihistamines. The following image shows the patient condition 10 days later, demonstrating significant improvement with therapy. In summary, we presented a female patient with a recent psychiatric hospitalization, during which several new medications were introduced. Shortly after treatment initiation, the patient developed a widespread skin rash accompanied by fever. Initially, no eosinophilia count was noted. However, facial edema, including involvement of the ear, provided an important clinical clue for diagnosing DReSS. In the following days, eosinophilia and an elevated liver function test were detected, leading to an increase in the patient's Registrar DReSS score. This case was especially challenging due to the need to balance the management of the patient's emotional symptoms while minimizing re-exposure to medication. The take-home messages are: facial edema is a hallmark sign of DReSS, providing an important clinical clue to differentiate between a viral rash and DReSS syndrome. Clinicians should carefully assess for this feature, examine the ears for any swelling, and request photos of the patient taken prior to the onset of the symptoms. Laboratory abnormalities, such as eosinophilia or elevated liver function test, may appear later in the course of the disease. Since DReSS is a progressive and ongoing condition, close monitoring and repeated evaluation are essential for effective management. Unfortunately, the family physician in our case missed the diagnosis. It is crucial to maintain a high index of suspicion for severe drug eruption, especially DReSS. Early recognition and immediate discontinuation of the suspected drug are critical for preventing complication and improving patient outcomes. Thank you for your attention. And now I would like to give the floor to Professor Gad.
Hello, everyone. Thank you so much, Mira, for this excellent presentation, and especially for making the right diagnosis for this patient. You gave me the credit, but the person who made the diagnosis is you. And I'm very happy and honored to be here today. So we're going to talk about DReSS, and I have like 30 minutes to share with you my knowledge. And I hope I will be able to provide you with some take-home messages and some really tips, clinically practical tips for you to use from today on. So you see my screen, right? Everybody can see my screen and hear me well. Yes? Okay. So great honor to share the floor with Mira. And, you know, being here as a speaker is very important to me, and I'm very, you know, it's very significant because I had the honor to be part of the co-founder of GLODERM Trainee Committee, and we always aim for free international knowledge transfer in dermatology. And I'm very honored to be part of this amazing program and also to share the floor today with Mira. I want to dedicate my talk in the memory of our dear friend who unfortunately died this year, Professor Markus Maurer from Germany. He was an amazing physician, fascinating and inspiring leader. I have no conflicts of interest for this talk, and I will discuss off-label use of medications. So I can say that my interest on the topic of cutaneous drug reaction already reaches more than 20 years of work. And I had the honor to do a fellowship with Professor Neil Shear, who's my mentor in Canada, for 3 years. And we wrote together, we co-edited this book, and we've written also various book chapters on the topic. So in the 30 minutes, I'm not going to be able to share with you everything, but this book is available also online. I don't get any money if you buy it, so there's no conflict. I just really, we put a lot of efforts to create this book. We have authors from 12 countries and 5 continents. It's really an international with, the same state of mind of Global Training Committee. So I actually looked today in PubMed and tried to analyze how many new papers we have by year if we compare, during the years on DReSS. And you can see that much knowledge has gathered, which is so important. And I really want to congratulate my friend Adela Rambi and her team, Adela Rambi Cardone and her team, for writing this beautiful review paper just published this month in the New England Journal of Medicine on DReSS. And many of the things that I'll present to you are also quoted from this nice paper. More of the reference for this talk. So I had the honor to write with my mentee, Dr. Sophia Labos. She's from the UK, and we wrote this book chapter, which will soon be published on the treatment of skin disease, the book chapter on DReSS. And I was also co-author in various papers on the topic. We had a DReSS syndrome meeting, so you can all look online if you want to read more about DReSS and hear more talks. It's online, free, and let's begin. So DReSS. The other names are drug-induced hypersensitivity syndrome and drug-induced delayed multi-organ hypersensitivity syndrome. Now, you see that the E is lowercase. It's not a capital E, and that's not a mistake. As Mira said, the first signs of the patients were without eosinophilia. And one of the things that is always, very challenging for physicians, because when they think about DReSS, they think eosinophilia is a must, right? Must have eosinophilia, which is not true. So the first take-home message is that we keep it lowercase e because DReSS doesn't always include eosinophilia. And maybe it will have eosinophilia later in the case. As Mira said, it's slowly progressing, but sometimes it doesn't include at all eosinophilia. The patient still can have DReSS. Okay, so please remember that. What about epidemiology? So DReSS is the most frequent cutaneous drug reaction in patients admitted to hospitals compared to other severe cutaneous drug reactions. We see it more in adults. The prevalence is 2 cases per 100,000 population, and the incidence is 1 case per 1,000 or 10,000 in patient receiving medication. Of course, there is a difference depending on the type of medication. What is this disease? So it's a severe idiosyncratic T-cell mediated drug reaction. The mortality rate reaches up to 10 to 20%. And the pathogenesis is very interesting. It's induced by a complex interaction between genetic factors, genetic predisposition, exposure to a drug, and viral reactivation. So as you can see here, the inciting stimuli are drugs and viruses, and T cells and eosinophils consist mostly of the immune response, but we already said not always eosinophils. What about the skin and mucous membrane? So the cutaneous manifestation of DReSS are diverse. Actually, any type of rash, which is important to remember, any type of rash, even target lesions, can be a manifestation of DReSS. However, the most common morphology is maculopapular morbilliform, as Mira presented in our case. And it typically presents consists more than 50% of total body surface area. And there could be mild mucosal involvement. So, this rush sometimes seems very, I would say, benign. And if you don't ask the patient about the fever, if you don't take blood tests, you may miss, the diagnosis of DReSS. And we can see here as well. As was well explained by Mira, facial edema is a prominent sign of DReSS. And please remember, when you see a patient, you have no idea if they have facial edema because you don't know how their face looked beforehand. This is why we ask the patient, show us your picture on the phone so we can compare. And the other thing, we looked at the ear. Ear edema is a very specific sign, and there is oblique earlobe crease, which is a novel examination finding in DReSS. Here, another earlobe edema. Now, what is important, the second take-home message here from my talk is that the severity of the skin involvement is not indicative of the extent of systemic involvement. You can have really a benign, which looks like as a benign exanthema, but it could be severe renal failure or hepatic renal failure or myocarditis, etc. So please don't take the skin as an indicator for the severity of the disease. The leg period. The leg period is really where the big, I would say, challenge for physicians, because it's usually a very long period, up to 8 weeks. And this is why, the patient is taking, like our patient, she was taking a lamotrigine, but she's been, seeing her physician 6 weeks after she started the drug, or something like that, which, we tend to think, or physicians tend to think, if you have an allergy, it will appear in the first day, maybe the first week, but not 8 weeks following initiation. But that's actually what's happening with severe cutaneous adverse drug reactions, especially DReSS. So you always have to go back 3 months to ask the patient, what are the new drugs? Now, the systemic involvement is very tricky. There is a multi-organ involvement consisting of skin, mucosal, hematological, and solid organ manifestation. The disease usually starts with a prodrome of flu-like symptoms. Something like, like people say, I felt I was like having a flu, malaise and pharyngitis and fever, lymphadenopathy. And then, usually slowly progressing, there's appear to be lymphadenopathy, various hematological abnormalities, sometimes eosinophilia, yes, but sometimes not. Actually, pancytopenia, which is more rarely, is correlated with a worse prognosis. So visceral involvement must be assessed, and not only on diagnosis. As you remember, Mira showed that her liver enzymes were elevated only a few days after she was hospitalized. So you need to assess all of that, and any type of, I would say, systemic involvement can appear, like kidneys, liver, lungs, muscle, myocard, etc. And it's very important to assess that. Let's talk about the hematological involvement. So as we said, usually eosinophilia, atypical lymphocytes, very important to ask for a smear. If you don't ask for a smear to look if there is a typical lymphocyte, you're not going to see it. And of course, leukocytosis, but as I said, pancytopenia, which is associated with severe prognosis. Systemic involvement, liver most commonly, renal next most common, and also lung and myocard, etc. And I will soon show you some cases so I can present it to you. Histology. Well, there's nothing that really is pathognomonic, okay? Of course, we do see eosinophilia many times. We can see interface dermatitis like we see in drug eruption, but sometimes we see things that are not really that specific. One of the clues to diagnose drug dermatosis, one of the distinguishing features, even to differentiate it between non-drug dermatosis, is having in the same biopsy multiple inflammatory patterns. So you can have, let's say, eczematous, interface dermatitis, lichenoid, all together. When you have various types of inflammation pattern, you think about drug. Severity score. So I'm sure, usually I ask to raise hands, but we are now doing webinar. So I'm just wondering how many of you are aware of the severity score that was developed by my good colleague, Professor Shihura from Japan, and was published in the JAD in 2019. And this score is not only important just, to make sense in what we're doing, but also it helps to tailor the treatment. So according to the score, we tailor the treatment. According to the score, we also assess whether viral reactivation has occurred. And you can see here, this is the score. And then you have this flow chart. So according to the score, whether if it's a mild case, they actually recommend even no need for systemic corticosteroids. I would say that I always use systemic corticosteroids, but according to the score. And then moderate cases usually use less than 50 milligram per day of prednisone, and then severe cases usually you use more than 50 milligram per day, and then you follow the patient and you assess the score. And if there's no increase in the score, okay, you just if there's decrease in the score, then you just taper down the corticosteroids. Whether there is increase or no change, then you need to think about reactivation and you do more assessment for viral reactivation. Now, the biggest challenge of DReSS is the differential diagnosis. So many diseases can look like DReSS. Fever, enlarged lymph nodes, morbilliform eruption, viral reinfection. Not surprisingly, our patient was suspected of having viral infection, lymphoma, and all of this that is written in the slides. Now, I want to share with you 3 patients that I treated at the hospital in the last few years, which will demonstrate really I would say, the challenge of diagnosing DReSS. So the first one, I would never forget her. I was a young resident, but I already was involved in, if you know, that was the Regiscar study, which is a European study for drug eruption, severe drug eruption. So I was very much, I would say, aware of this type of severe drug eruptions. So I was sitting and we got a consultation from the internal department, and it was a 17-year-old female. It was written that she was recently diagnosed with lymphoma, which manifested with high fever, enlarged lymph node. They conducted FNA from a lymph node showing a typical lymphocyte. And then she was referred to our dermatology clinic because she had a new skin rash. And they thought, maybe it's a skin rash of the lymphoma, maybe it's related to the treatments. Then I saw her and I saw fever. I've noticed enlarged lymph nodes, atypical lymphocyte, but I also noticed that in her file, she started using carbamazepine 4 weeks prior to the initiation of this, all the rash and all the symptoms. So in my eyes, I was like, the patient has DReSS. I was very shy to say that. I was a young resident, but I said I must be, keep my integrity. So I said, maybe you can stop carbamazepine and then provide the patient with prednisone and then follow. And apparently the lymphoma disappeared. It didn't disappear because the lymphoma never existed. This patient was wrongly being diagnosed with lymphoma. And that typical lymphocyte of the lymph node, you may ask, this something that we see in patients with DReSS. Second case, I was already a senior, and I came to do, we have hospitalized patient in our department, so I came on a Friday morning to do a round, and my resident said, there's a young man in the cardiology intensive care, And he's connected, he has myocarditis, viral myocarditis, and he's connected to all the machines. So they asked us to come to see him because he has a urine rash. So my resident presented me the patient, fever, myocarditis with elevated CPK, feeling very bad, and having a rash. But then I looked at his drugs, and apparently he started minocycline for acne 6 weeks prior to the symptoms. So for me, I said, you know what, let's just stop the minocycline and give the patient prednisone. And apparently the viral myocarditis disappeared. It didn't disappear, it was just never viral myocarditis, it was DReSS, induced by minocycline. And the last case is a patient hospitalized in internal medicine unit with a diagnosis of acute pancreatitis. And they couldn't find the cause for the pancreatitis. They did various imaging, nothing was really, they couldn't find the source for that. So my friend who's a pharmacologist, he said, Roni, maybe you come along. He has a mild rash, maybe you can find the connection. So then apparently, when I talked to him, he started a new medication for his depression. Again, something like 5 weeks prior to starting this, fever and all the symptoms of pancreatitis. So we discontinued the medication. We gave him prednisone. Pancreatitis was over. It was resolved. So these cases really demonstrate how tricky it is and how you need to keep it in mind. You know that the eyes see what the mind knows. We see what we know, which is true in everything in life, especially in dermatology. We see what we know. Okay, so how many of you are using the DReSS validation score? I hope you are using it. It's a wonderful tool. It's a validated criteria. Please use it. What about etiology? So you can see here from various papers, the 3 main groups are anticonvulsants, the most common DReSS-inducing drugs, right? Anticonvulsants, allopurinol, sulfonamides, which could be sulfasalazine and sulfamethoxazole, which is Resprim or Bactrim, depends on where you are worldwide, and antibiotics such as vancomycin, minocycline, etc. In the New England paper, as I told you, just published this month, they report that the 5 drugs in the USA that account for most of the cases are allopurinol, vancomycin, lamotrigine, carbamazepine, and trimethoprim sulfamethoxazole. And this is important because you need to keep high index of suspicion when you see a patient with these new medications. Okay? Remember, the eye see what the mind knows. But then if you look at this a table that we've written in our review paper on DReSS, you see there it's much more, like many drugs were reported. And interestingly, in the last years, a new group has emerged, which antineoplastic and immunomodulator drugs. And I want to share with you a very interesting case. But before that, I just want to show you how many cases of checkpoint inhibitors associated DReSS. So this case, I've written with my mentee, Dr. Christina. She's already a dermatologist. We've worked together when she's one of my really favorite mentee. And we wrote together this very interesting case. So we had a case with vemurafenib inducing DReSS. But interestingly, the patient who had metastatic melanoma had regression, spontaneous regression of her melanoma following the DReSS. It's like the immunological reaction that occurred because of the DReSS also managed her metastasis, her melanoma metastasis. And we looked at the literature, and apparently we were not the first one to report that. There were other 2 cases when we presented that reported the same. And you can see here on the left, you can see here the metastasis of the patient. And then following DReSS, it's all disappeared. And unfortunately, we treated her for the DReSS. Not unfortunately, we're fortunate to treat her for the DReSS. But once she was treated, the metastasis came back. But we thought that this interesting phenomena may shed light that may DReSS serve as a research tool for developing treatments for melanoma. But this is just, a sidekick that I wanted to share with you. Let's go to treatment. So what about treatment? The first and important thing is discontinue the drug. Discontinue the offender drug. It may sound so, like logical to you. Why do you even say that? That's so clear. Well, apparently it isn't. I've seen in my career so many cases, they were given IVIG, they were giving, corticosteroids, but the drug was never withheld. So discontinue the drug, and you need, as Mira said, to discontinue all the drugs, if possible, because you never know, to begin with, what is the offending drug. And then you manage the patient. First of all, we hospitalize all patients, and I do recommend to hospitalize because you want to do drug work in the next few days, and you want to give systemic corticosteroids in high dose, which will necessitate monitoring blood pressure, the glucose level, psychiatric and emotional response to high dose corticosteroids. And then you hospitalize the patient, you discontinue the drug and all drugs that are not necessary. And then you manage it according to the severity. You can use the Japanese severity criteria. You can use other severity assessment that I will share with you in the next few slides. But mostly you need to remember that according to the systemic involvement, you tailor the treatment. So glucocorticosteroids, prednisone, or steroids IV is the mainstay of treatment. However, sometimes you need to give more treatments. Sometimes you need to give antiviral treatment or IVIG, etc. An important take-home message. Please remember, systemic steroid should be administered for a long period of time, at least 3 months. And you need to slowly taper down the treatment with follow-up of systemic involvement and viral reactivation. Please remember, the skin does not mirror the systemic involvement. You cannot take the skin as a factor, only as a factor, when you decide to discontinue prednisone or even to lower the dose. What needs to be tailored, the factors that you base on them, the tailoring of the prednisone is the systemic involvement, which can slowly appear. You never stop the drug, you never stop the prednisone abruptly. You do not. And there are other treatments other than steroids. And cyclosporine, we don't have time, cyclosporine and IL-5 receptor antagonists are important, and you can read more about it. Now, I want to present to you this paper. I had the honor to be co-author that we published in JAMA Dermatology in January this year. It's a Delphi on how to manage patients. And just you can see there's a baseline diagnostic workup that you need to do. And also there is a complementary according to the specific organ that is involved. And in cases where you suspect viral reactivation or you plan long-term systemic therapy with prednisone, you want to do screening for hepatitis B and C. Here, we created another type of classification for mild, moderate, severe. You can use either. Just remember, you tailor the treatment as seen in this table. You tailor the treatment according to the severity. Long-term complication, very important. Organ dysfunction, psychiatric complication, which include depression, anxiety, and also post-traumatic stress disorder. Please monitor that. And new autoimmune diseases that can appear months after the patient had recovered. And this is why in the follow-up care that we've written, we recommend regular follow-up. And we recommend assessment for autoantibodies, thyroid function, and to offer patients psychological support. I do recommend you to use this beautiful JAMA Dermatology patient page that was written by my friend, Professor Elizabeth Phillips. It's a beautiful tool to use when you want to give your patients something valid for them to read and understand what is their disease. You don't want them to Google. You really don't want them to Google. You say, you want to read about it, let me give you, and this is JAMA Dermatology patient page, and you can print it and give it to your patients. Now, what's next? We don't have much time, but I'm going to say really 2 minutes. We need to talk about the future. And the future is going to be based mostly on pharmacogenomic and artificial intelligence. We need to remember that in order to develop DReSS, we need to have accumulation of risk factors. Part of these risk factors are genetically related, specific HLA. And these are low-hanging fruit. We can conduct genetic screening to prevent DReSS. And this table that we've written for lead drug book, it is a very important paper and the table. And the reason is because you see here, this is the authority recommendation. So let's say you want to give carbamazepine. Those are the HLA you need to do. You need to do genetic screening. Exactly also for oxcarbazepine and phenytoin. We know that authorities recommend conducting genetic screening. However, look at the screening programs. Where do they exist? Only in Asia, which is very unfortunate. Only in Asia, not in North America, and not in Europe. And this is something that has to be changed. And this is one of my mentees, Dr. Felix Hahn from UFT, University of Toronto, and we've assessed why are we not doing genetic screening. There are many reasons for that, but one of the reasons we found is that lack of knowledge among physicians for the ability to conduct genetic screening. And in the future, I promise you, all of us are going to have a chip, and before we're prescribing somebody or given a drug, we're going to assess the medication. We're going to see if it's in accordance with our genetic background, and all the mechanism of multidisciplinary team is going to change. We're not going to take a drug and just hope that everything will be okay. And I hope the future will be very, very soon. AI, we can't ignore this beautiful, beautiful innovation. Okay, AI is already being used to monitor pharmacovigilance and to assess adverse drug reactions. And the combination of pharmacogenomic and AI will be the future of cutaneous adverse drug reaction in specifically, but adverse drug reaction in general. And for me, the most important person today in the webinar is Tasha Tolivar. And I hope Nancy is joining us as well, but I'm not sure she could. Tasha is the founder and the executive director of DReSS Syndrome Foundation. And I know, Tasha, I've seen you, you are with us, and I want to really thank you and congratulate you for establishing the DReSS Syndrome Foundation. And I will show you a movie that both Nancy and Tasha prepared for you to hear their story. And you can see this ribbon that was created in collaboration with DReSS patient community as a symbol of hope and change for DReSS awareness. So let's listen to Nancy and Tasha in the next video.
Hi, I'm Tasha Tolivar, founder and executive director of the DReSS Syndrome Foundation and mother to 2 beautiful girls, one of whom we lost to complications from DReSS syndrome at the age of 16. My perfectly healthy daughter, Izzy, developed first signs of DReSS, fever, and an maculopapular rash 2 weeks after starting Bactrim, prescribed for moderate acne. Delayed diagnosis, proper treatment, and failure to recognize symptoms of myocarditis is what led to Izzy's tragic but preventable death. We learned that DReSS is a progressive and tricky illness. Even after stopping the Bactrim, the symptoms continued. Izzy's course of illness involved a progressive rash covering most of her body, swelling and extreme facial edema, and peeling of skin on her hands and feet. Systemic symptoms included liver and renal failure, hemophagocytic syndrome, and severe reactivation of human herpes virus 6. Interestingly, although she had atypical lymphocytes, eosinophilia was never noted during her illness. Izzy improved with high-dose prednisone, but upon lowering the dose, she became weak, developed tachycardia and hypotension. This progression was fast. Izzy went from being at school one day and in the emergency room the next. Autopsy revealed that she died from eosinophilic myocarditis from DReSS. Please go slow on the prednisone wean. Draw regular labs and follow your patients for a long time. And please check the heart. Thank you for listening.
Hello, my name is Nancy Sakachi, and I'm a founder from the DReSS Syndrome Foundation. My healthy 16-year-old daughter Hannah was prescribed minocycline for acne. After 21 days, she developed swollen glands, low-grade fever, rash, and malaise. After 5 weeks of prednisone and significant flares, her dose was lowered from 20 to 10 milligrams. A few days later, Hannah's heart failed sitting in her doctor's office. After an Impella was inserted at the hospital next door, she was flown to Cedars, where she arrived in cardiac arrest. After ECMO, Hannah had fasciotomies flaying open both her legs, 2 open heart surgeries in the first 2 weeks, and the loss of all her major organs. She had a bivalve implanted and later removed, endured hundreds of x-rays, scans, severe starvation, the loss of her colon and part of her pancreas. Hannah coded 11 times while being treated for minocycline-induced DReSS syndrome until she died 102 days later in ICU, just 2 weeks after her 17th birthday. Her final diagnosis, minocycline-induced DReSS syndrome with multiple organ failure and myocarditis. All rare means is that it can happen. Thank you for listening.
So I want to thank you again, Tasha and Nancy, for creating this important foundation. And I want to invite all of you who are listening to us, if you have patients with DReSS, please refer them to the foundation. They provide a lot of support for patients. And please, I fully recommend you to make the connection for your patient with this very, very professional and important foundation. So before I close my talk, I want to thank my mentors on the topic of cutaneous drug reactions, Professor Sima Levy from Israel and Professor Neil Sher from Canada, who gave me the passion and the knowledge on this important topic. I want to invite you all to join the World Congress of Dermatology in 2027, who will be in Mexico. I am honored to be an ambassador for this important meeting. And now we're going to start the Test Your Knowledge on DReSS. Thank you. So I'm going to ask you a few questions that I think we've answered, but we'll see how you do it. So the first question is, which of the following drugs is highly attributed to inducing DReSS syndrome? Allopurinol, paracetamol, penicillin, or propranolol? Please. Okay. Okay, tell me, like, we're waiting. Okay, so please give your answers. Okay, so 41 of you answered, all of you answered, thank you so much. And by the way, we're gonna have a picture, all of us gonna have a picture. So please don't leave the meeting before we make the picture for all of us together. Sorry. Just please don't do it. When I'm done with the poll and the question, we're going to have a photo before the discussion. So please stay with us. So the right answer is allopurinol. Yes, and 88% of you answered that correctly, which is great. I'm not saying other drugs can also cause, but the following drugs is highly attributed. Remember, anticonvulsants, allopurinol, antibiotics such as minocycline, vancomycin. Okay, next question. Which of the following signs help differentiate between DReSS syndrome and viral eruption? Enlarged lymph nodes, sorry, there's a typo, enlarged lymph nodes, fever, morbilliform rash, or facial edema. Which of the following signs help differentiate between DReSS syndrome and viral eruption? You all can remember the patient that Mira presented, the photos we showed you. Okay, we're waiting for all of you to give the answers. Okay, so all of you answered, and the right answer, as you all knew, nearly all of you knew, 87%, is facial edema. Remember the patient, facial edema, also earlobe edema, very important. Enlarged lymph nodes, fever, and morbilliform rash are actually present in both viral eruption and DReSS. Okay. Test your knowledge. Which of the following long-term complication of DReSS, which of the following are long-term complication of DReSS? Autoimmune disease, anxiety and post-traumatic stress disorder, organ dysfunction, and all of the above. Okay, waiting to get all the results. Okay, here we go. Yes. Okay, here we go. 100% knew it. Perfect. Autoimmune, anxiety, organ dysfunction, all of the above. Okay, this is perfect. So, thank you so much. This photo was taken in Jaffa, in Israel, and we are having, some challenging time of our country, but we are strong, and we hope for peace soon. And this is my email. And this is my QR code for my LinkedIn and WhatsApp. Please feel free to contact me. Thank you very much.
Right. Thank you so much, Professor Dodiuk-Gad and Dr. Hamed for the wonderful presentation. So we have a few questions in here. So the first one is HLA genotyping seems to hold potential for predicting risk for reactions to drugs such as vancomycin. However, in the US, there's been it's challenging to access such testing. And is there any way for a patient in the US to have this done?
Okay, so I know in Canada there is, because I worked in Canada. To be honest, I don't know exactly. I'm quite sure that you can do it in the US as well. And I think at least, look, the FDA, if you look at the FDA label for, let's say, carbamazepine, it says that for Asian people, you must do it before prescribing carbamazepine. So potentially, if you don't do it, you're actually risking yourself, I would say medically, legally, okay? So I think you should really find out. That is important. The problem is that we usually don't prescribe this medication, right? We don't. They come to us after they've been already prescribed. But let me tell you what I do. If I had few patients in the burn unit in Canada that were a patient had allopurinol as a trigger for SGS and 10, okay, as well as severe cutaneous drug eruption. And I've taken the test for the patient even afterwards. And why did I do that? One, because I really want to make sure that allopurinol, for instance, was the cause. When HLA-B star 5801 was positive, then I knew that was the cause, and I could let him know, it's allopurinol. You can go back to all the other medication that we thought were suspected, because we have genetic analysis showing that you are predisposed to developing this type of reaction due to allopurinol. So even, I just encourage you, especially the young physician, ask about it, and if you have a response, also you can conduct it after the response. Of course, the future is for genetic screening. And just so you know, in Taiwan, when they incorporated genetic screening to prevent SGS and 10, they nearly diminished the disease from carbamazepine in Taiwan. And they published that in the New England Journal of Medicine, that based on the genetic analysis, because in Asian population it's more popular, so this is why it was for them, recognized to be cost effective. But I know that in the future all of us are going to do it. I just hope it will happen sooner than later. Thank you.
Thank you so much. The next question that we have is, I guess there's two questions that are closely related, so I'll ask them together. Of all of the diagnostic criteria available, is there any that you currently prefer for the diagnosis of DReSS? And also, has there been a move to validate any of the diagnostic criteria available for DReSS?
Yeah, so the one that I showed you, the Regiscar validation of DReSS, it's validated. And that's the one I really recommend you to use it. My residents who are here with us today on the webinar, they know it. Like you can't present to me a case of DReSS without doing the Regiscar score. You can't. That's like you do it, you present the patient, and then you say the score is. And the score changes, like Mira presented. Few days later, when she had eosinophilia and elevated liver, yeah, so you need to remember it's a slowly progressing disease. So you do the score, but then you follow and you do the score after a few days as well. Yes, use the score. It's really, you can just Google that. Regiscar score for DReSS, it's a validated score.
Great, thank you so much. And how frequently do you end up using immunosuppressive therapy to manage stress at your medical center, and what guides this decision for you?
Yeah, I'll be honest, like I've been in many conferences talking about topical treatment for DReSS, okay? I don't do it. Honest to God, I don't do it. The reason I don't do it because I don't know when I start the treatment, even when the case is a mild case with no systemic involvement, I don't know if the next few days I'm going to have high liver enzyme elevated or things like that. So for me, I always take the cases very cautiously. Like Tasha presented her daughter, and Nancy as well. They start, you start with a case, you don't have eosinophilia, maybe, it seems, and then very abruptly they can deteriorate. So I always start with systemic prednisone, systemic corticosteroid, usually prednisone. I go 0.5 milligram per kilo usually. If the case is very, very severe, I will go with 1 milligram per kilo. If I think that, there's difficulty slow breathing, swallowing, sorry, or something feels more even pronounced, and I will go with pulse treatment of corticosteroids. I usually start with corticosteroids, although cyclosporine, as I showed you, and other treatment may be beneficial. But I start with corticosteroids.
Okay, thank you so much. We have two more questions here if you have time.
For sure.
So, have you had any reason to do a bone marrow biopsy or immunohistochemistry? So, this individual's patient had differential diagnosis of DReSS, but then biopsy showed blast cells, IHC strongly stained for myeloid lineage, which can be seen in hypereosinophilic syndrome. So, do you think that resistant cases should be considered for bone marrow
Yeah.
biopsy?
Of course, yes, yes, yes. And you always need, it's a multidisciplinary team, management. You don't do it by your own. I mean, you always need to bring in the nephrologist or the cardiologist or the hematologist. And we had a very, a sad case of a young child who came with DReSS syndrome, and he came quite late. And he had pancytopenia. And, he developed pancytopenia, so he had bone marrow transplantation. They've done bone marrow, they've seen that it's related to the DReSS. And unfortunately, he had transplantation, but it failed and he died. So please take these cases very seriously. I mean, we do need to remember there is more than 10% mortality rate, and you can't, predict very early how the case is going to evolve. So you need to be very cautious. And yes, if you need, you do bone marrow, you do everything you need in order to differentiate and also to assess the hematological involvement.
Thank you. This last question is very quick, short. So how big is the chance to get DReSS again from starting a new medication? So this individual got developed DReSS from
Yeah. So
dicloxacillin.
we talk about like one case per, like in patient taking medication. So we say something between 10,000 1,000 to 10,000 cases you will have. But it really depends. On patient taking allopurinol, it's much higher. On patient taking carbamazepine, it's much higher. So it really depends on the drug. And please remember to look for these high, I would say, high risk drugs.
Thank you so much.
Thank you. Thank you so much for the opportunity. And thank you. I want to thank Mira for her excellent presentation. And I want to thank everybody who joined us today. And you are the ambassadors of this GLODERM trainee committee. I want to thank all the amazing team of the GLODERM trainee committee. And thank you so much. It's a great honor to be here. Thank you.
Thank you all so much. Thank you, Prof. Thank you, Dr. Mira. I think we've learned quite a lot from the webinar today. And if you want to learn more about our GLODERM educational webinar series under the GLODERM training committee, kindly follow us on our social media handles, and we'll share more information on that. And you can also find past webinars on our YouTube channel. So see you next month. Thank you.